And he looked right at this child and he said, death is contraindicated in children. Phrasing is that intervene before deterioration occurs.
In pediatrics, we teach if you don't cruise, you don't bruise. And that is definitely true.
Engine 23 and Medic 23, Larpenteur Avenue West and Fry Street. Police on scene. Shooting. Stand by for police. Box 546. On fire off score. Time 21:07.
Hey everyone, welcome to EMSconnect On Shift, your go-to podcast for everything EMS. Sometimes we're going to educate, sometimes we're going to review EMS articles or books, sometimes we just hang out with badass people and BS, but I'll tell you what, every time we're going to have an absolute blast. I am your host, Sean Pitts. I'm the head of education for EMSconnect. We are a top-tier EMS education organization that offers more education than you'll ever need. We have a website with hundreds of hours of education. We got online EMS refresher courses, and we even offer on-site courses. Before we jump into this episode, please take a moment to go to whatever app you're listening to this on right now and subscribe to our show, give feedback, and give our show a rating. Every rating you give truly elevates this podcast and makes it easier for others to find us. Please help us spread the word about EMSconnect and the On Shift podcast so everyone can get educated. The better Dr. Karina Dierks.
I am honored to be here. Thanks for having me. I am a practicing pediatric hospitalist in Spokane, Washington, and that means I see patients in the hospital and not outside the hospital. Mm-hmm. So I'm glad to be joined by Sheri, who brings that perspective.
Sheri, welcome back as always.
Thank you. It's good to be here. And my name is Sheri, and I work with LifeFlight and have for quite a few years now, and bring some of that pre-hospital education to share with our listeners, and kind of glance off of what Karina brings to the table and how we can work with that in hospital and pre-hospital aspects and time together. So very good.
Awesome. Well, I turn it over to you guys and look forward to what you guys have to say.
Okay.
Great. Thank you, Sean. Okay, so the objectives are posted here on this slide. Really, this is just meant to talk about pediatrics, some of the special things that are unique to the pediatric population, and hopefully provide a few tips and tricks for interacting with these little patients.
Yes, absolutely.
And then there's some seasonality to pediatrics, and we'll get into that, and then some red flags that we hope we can call attention to so you don't miss them in the field. So the elephant in the room. I don't know, Sheri, why don't you start with this one? Because I think this affects you more than me.
Yes, it's arriving on scene and having a pediatric patient and having family around. It's just a scary aspect for our pre-hospital providers. And there's a joke that I love, and it is a pediatric specialist and a paramedic arrive on scene, and there's a woman who is complaining of severe abdominal distension and abdominal pains and cramping, and states that she just had a gush of water that came from her, and she goes, I can't be having a baby. I don't think I'm having a baby. It's a snake. There's got to be a snake in me. And the pediatric specialist goes, man, I hope it's a baby. And the paramedic goes, man, I hope it's a snake. And that kind of defines how that perspective of coming upon a scene with a baby creates that nerve. And it really is a sensitive subject when you have parents that are on edge and nervous. And when we show up, we are going to make the baby cry. We are going to do things that are going to irritate and upset the child, getting an initial assessment, maybe starting an IV, and oftentimes upsetting that little patient also upsets the parents, and it can bring a lot of emotion and high stress to the situation, especially the more critical the patient is. And so there's a whole nother element when you arrive to somebody's house and what you see pre-hospital. And it can be nerve-wracking. It can be, especially since it's a population we don't deal with and see as frequently as our older groups. And so keeping them calm, doing age-appropriate interventions, being mindful of our little patients and what would help distract them, what would help distract the parents. And then in hand with that, getting report from the parents. They know that child best, especially if they have a chronic illness, and respecting what the parents know. That's a big element too. So a lot of elephants in the room when we come across our little population there.
Yes. And I would like to echo and call out a few of the things you said. In some ways, the parents can be your very best ally and your worst enemy.
Correct.
Depending on that like emotional dynamic.
Yes.
And in some ways, the more critical the actual patient is, the more escalated that emotion might be. And, you know, as a on-hands provider, you need to be with your whole brain and your whole skill set working on the actual patient. You know, and if you don't have somebody on your team who can kind of back you up and provide reassurance to the emotional parent, it can really escalate quickly.
Yes, it adds another level to it. But like you said too, if you have a mother or father of a child that has a very critical, long-standing illness, they're usually calmer than we are when we get on scene too, and they are such an ally to have. And usually I'll continue whatever treatment they've initiated and just go with that, because their understanding and awareness of what that little patient's dealing with is far greater than what I would ever have. And so they can definitely be a benefit too, like you said.
Definitely, because they've lived through it before. They're not generally afraid at that point of like touching them, picking them up, moving them around. They know that they're not as fragile as they may look to the person who has just arrived. The emotion, I think, goes both ways, though. You know, for everyone in the room, I mean, you as a provider start feeling an escalated emotion because you're feeling it from the parents. But I think, and I see this, I think, more in the hospitalized child who is stable. You know, it's not an unstable situation like you might be arriving into. By the time they're with me, things are stabilized. But as parents talk to us, and if they start escalating emotionally, a patient who is not critically ill, but is in the hospital, who might be, you know, playing Legos while the parents talk or something, can like look over and see that their mom is all of a sudden crying and starts to maybe cry or like whimper or crawl over into her lap. And so parents can definitely help you by regulating their own emotions and calming, or if they are really escalated, stepping out, recovering their selves, and then come back in and actually provide legitimate soothing power to for their kids to regulate their emotions as well.
And they truly feed on the energy we bring to a scene. And so having game face, that's it, just game face, and showing up and having that confidence, even if it's not necessarily there when you initially arrive, just getting your ducks in a row and taking in the scene, and then that confidence and calmness and being able to provide care and competent care, is the parents will feed off of that too.
Absolutely, they will. For sure. Okay. Well, yes. Good insights. Okay. So pediatrics is obviously birth through 17 years and 365 4 days. And then all of a sudden they turn 18 and they're completely different. Sheri, you were mentioning those maybe chronically ill kids. There are some pediatric subspecialists who do take care of certain diseases longer than 18 years. So I'm thinking of kids like maybe cystic fibrosis or congenital heart disease. There's some of those disease processes that used to die in childhood and are living longer now. And so there's this little buffer zone. But in general, 18 and under is pediatrics, and 18 and above is going to the adult side. I think it's fairly obvious, the rest of the slide. There are, in pediatrics, one of the things that I think is important to recognize is that the development, you know, pediatrics is about supporting healthy development of all children. And what their anatomy looks like at age 1 month is different than 1 year, is different than 10 years, is different than 18 years. And same thing with what they're physically able to do. Some of their physiology changes through that time frame. And so, you know, it's the development through those first
Right.
couple decades.
And I know showing up on scene, I'll usually just draw a quick line when I'm doing a rapid assessment and I walk in a room and I look and I see my patient. And if they have any type of body development growth, I'll go down a mindset of, okay, I'm going to do more procedures or more interventions that I would lean towards an adult. And then I look at my younger patients, see obvious child, like larger head size, just adipose tissue, and those that I go into the pediatric mode with that patient. So I'll kind of draw that line right when I walk in on scene and then make a quick decider, pediatric or more of an adult management. And then, and the kids differing from adults, I was going to ask you what you felt about that concept of kids are not little adults, so they need to be treated very differently versus if you were going to do the treatment to an adult, you should definitely do it on your child. And I kind of have been practicing and adjusting my mindset to, if I'm going to do it on an adult, I will do it on this 5-year-old. I had a child that was deteriorating respiratory wise, and the next phase to buffer while he was still alert and maintaining his airways was to try BiPAP. And I had some physicians and even the parents were mentioning that I don't know if he'll do the mask and I don't know if he'll take the mask. And I was able to sit down on the bed and talk him through it. And he did better than my 55-year-old patient that I just had on BiPAP. And he took BiPAP like a champ and it turned him around. And I thought in my head, I would not even doubt doing that on a 55-year-old patient. I shouldn't have a hiccup when I know I need to do it on this child as well. And do you feel that concept works, that if do that intervention and don't hold back? If you were going to do it on your adult, do it on your little patient too.
Yes, I strongly think that. I mean, I can't off the top of my head think of something that, except that would be contraindicated. But in general,
right.
Yes, I absolutely think that's true. And I also think that some things are hard because I think we'll get to it in the next slide here, that kids, if you're sick or hurting, might not be compliant, might not be following directions. But guess what? Kids don't always follow directions when they're perfectly well.
Right.
So in some ways, if you come across a truly critically ill child, you might not have to worry about them not tolerating it because they might need something so bad that they are not able to fight.
Yes.
And so I kind of like kids feisty. It makes me feel like they're not as critical.
Yes. Yep. Be upset if I'm starting an IV on you. Be mad that I'm going to do an intervention and frustrated with me. That's okay. It's when they're not that I start to get that sinking feeling in my chest and think, okay, I've got to move quickly because we're
more critical.
We're deteriorating. Absolutely.
Yeah. So I think if you can recognize that I'm going to do the intervention that this kid needs, even though it's not what they want.
Right.
And if they're able to fight me so hard on it that I can't get it done, then we're going to bumble through.
Right.
And it'll be fine until we get them where they need to be.
Exactly. Because the big one, I think right now in this season, I think we'll talk about it too, is nasal suctioning. Guess what? Kids don't like that.
I don't think
Shocker.
Adults would
I don't think
either.
any adults, exactly. I wouldn't like it if you did it to me either. So it's just one of those things where, but we have to do it. We need to do it. And so there's just some things that we're going to have to do and to help that child from deteriorating.
Yeah. So as far as this slide goes, you're absolutely going to stumble across the crying kid, and that's just the truth of the matter. Get used to that.
Yep.
Refusal to leave the parent and caregiver. I understand in some of your transport rigs, you have like limitations of space, but if you're in a situation where you can use a parent or caregiver to be your soother, then use them as a tool to help you kind of calm and carry the kid or whatever.
And that leads to another question that arises when we have pediatric patients in the pre-hospital setting is what is legally allowed when you're transporting a patient. And when we're in ground transport, it is very, very, very frowned upon. I don't even think some companies allow it to have the parent hold the child. In a car seat, you can attach the car seat to the chair, but having the parent hold the child is not something that is approved in most companies, but in flight, we can allow, just like flight rules on a plane, you can allow a parent to hold a child. So we have a little bit easier leeway working in the air transport, is that we can strap off the parent to our stretcher, and then the family member can hold our patient, which does help a lot, with the caveat that I'm removing that child from your arms if anything changes. And so there is that situation where we're holding the patient, where I can see them, I have my hands on them, they just happen to be in your arms, and you cannot stop me from taking this patient out of your arms if anything happens. And so there's a few little caveats there, but sometimes you just need the patient to be calm and just get them to the definitive care. So however that works.
But parents also know, like, this is so-and-so's favorite stuffy, or here's their little binky, and kids arrive at the hospital all the time with these strange, ratty little things.
But it's the thing.
It's the thing. Yes. As far as being uncooperative with the exam, that's definitely true. And it just takes practice, like knowing what you need to examine on that patient and be willing to examine it, even if you are getting screamed at. And the more times you practice doing it, the more comfortable you'll be. For instance, like palpating a belly, when they're screaming, you might think, gosh, that's really firm. But after a while, you start to realize, oh, when they pause to take their giant breath to scream at me again, I can feel that it's soft in between their screams versus a rigid abdomen where they're crying everywhere you touch, but they're really upset when you're anywhere near their little belly.
Very good tidbit. Exactly.
Okay. This is so silly. Yes, I agree with the disclaimer that you shouldn't be talking to you as an adult. Actually, this, as a pediatrician, this is something that I talk to my patients about. Stranger danger.
Yes.
This is a safety thing.
Yes.
So as adults, we should not be approaching children. However, if you have friends and family, do take every opportunity to interact in a developmentally appropriate way with kids, because you'll recognize that a 2-year-old is different than a 10-year-old. And honestly, kids are emotional sponges. They are natural mimickers, and you can learn to engage kids at all ages. I mean, from a very early age, humans know how old they are, know their name. What is their favorite color? What's your dog's name? Those are kind of polite conversation questions that you can have with a child, as opposed to, where did you go to school? What do you do for work? Those are adult, casual conversation pieces. So as long as you have a few of those in your back pocket to pull out for casual conversation, you should be good to go.
Yep. For loading in the helicopter, I always mention that we're going to fly through the air like Superman. Things like that, age appropriate, where it's exciting. We're going to be zipping through the air like Spider-Man or Superman does. And it becomes exciting and not a scary thing. So getting on that age appropriate level. And for me, around friends that have children and babies, my thing was always touching them to see where I would get an IV. That was finding veins, palpating veins, because that's the biggest nerve-wracking thing that I do, at least it feels like I do on a child, is getting the one poke and done on a child. And so I would always feel for veins and kind of perfect my where do I get that IV at kind of palpation.
And some of those little hands can be just so very chubby. Yeah, that's true. Anatomic differences. Speaking of chubby hands in babies are pretty darn cute, but it is harder to get IVs through them.
Yes.
I think you already mentioned this. Proportionately, their heads are larger, maybe making babies a little bit bobblehead wise, which I think is very important then when you're thinking of the airway and how to manage it and things like that.
Exactly.
They're poorly coordinated. Yes, at some ages of development they are, and then by the time they're in their teenage years, I think they might be more coordinated than I am right now. So
exactly.
Again, it's developmentally related. And then everything goes in their mouth. That's true, definitely in those toddler years.
Yes.
Hopefully not so much as they get older.
Hopefully.
Yeah.
But yeah, knowing that their heads are larger and that the bobbing head, when we have a respiratory difficulty and positioning of the head, they can close off their airway, and just things to be mindful of when you see your child, and observing that because they're built differently, they might have innate complications with how their bodies handle stress and even their glucose storages, things like that. They just require a little bit more assessment and intervention, and kind of just double checking for the unobvious things that could be going on too. So get a blood sugar.
Get a blood sugar. Absolutely. Anatomically, this is definitely specific for those infant years. The anterior fontanelle, I would say, is kind of like a pediatrician's handshake. We're kind of always just passing our hand over their head to see what's what there. Most people recognize this as called the soft spot in a baby. I think of it as a pop-off valve for pressure inside the head. And so if it is sunken, it can mean a baby is dehydrated, is anemic, or chronically malnourished. If it is puffy or bulging, it could be that, they have increased intracranial pressure, which is usually due to infection or trauma. This is a picture that hopefully projects of a sunken fontanelle. And then this is a bulging fontanelle. And I would like to say, to me, these seem visually quite pathologic in appearance. I do see kids in the hospital sometimes who maybe just have, I don't want to minimize this, but like a little viral meningitis where they're a little generous or full in their fontanelle. But we'll just say it's like upper limits of normal. It's not something we intervene on.
Right.
So in most cases, the fontanelle is just a clue that this is something that is bothering them that we should be looking into, and then managing whatever the underlying cause is.
Absolutely. Because when we arrive in pre-hospital, we don't know what's going on. We don't have lab work. We don't have x-rays. We don't know. And so we need to use these clues and throw it into your assessment, just putting your hand across the top of the head and just a quick assessment to determine maybe this could be going on. And so you don't miss something. We have a lot of little nuggets that have quite a bit of hair too. And so it could be something that you just don't even think about because they have all this cute little hair, and just run your hand across the top of the head and just a quick little, I wonder if, and then you can add that to your compiling your assessment and maybe get a few more answers to the clues you're given.
And to me, the fontanelle is one of those things where the more you do it, like if you do this to every baby's head you see, then all of a sudden you start doing it and immediately feels, that feels
that's
full,
different.
Or that's different.
Yep.
But if you never do it except when you see an abnormal kid, then you're like,
Yep, exactly. Know what's normal. And that's the big thing. If you recognize normal, then it's more obvious what's abnormal.
Definitely, that's true. So bones and spine anatomically obviously are under rapid development in those baby and toddler years, actively growing. So some of these bullet points are more specific for certain timeframes. So bones are more elastic and flexible. That's obviously true as a neonate. You are
very
born vaginally, so you need a little squishiness to you. When you guys see a kid, or then when I'm interviewing a family, the mechanism of an injury matters a lot to me. So I am in a situation where I am asking a caregiver to say what happened, and they have to report a mechanism of injury. You guys might be in an environment where you can see a little bit more of what that mechanism looked like. And so that sort of handoff to the hospital or in your report does become valuable, especially in those situations where there is a question of an abusive trauma.
Exactly.
And if you can report something that like, oh no, we came into the bedroom and there's the bunk bed and everybody's standing right around little Johnny.
Right. And if it seems age appropriate or something that happened just as a complete accident, yes, there is a difference, and you get a feel for the environment. And there are sometimes, if you can, not obviously, but taking photos of any type of scene situation, car accident, area of injury, to get a good picture of where the incident occurred. Sometimes that helps paint a picture as well. And so, and anytime you might have a report from the family about what happened that doesn't seem to flow or correlate with what you see, what the injury is, then definitely mention something in your report to the hospital and tell somebody what you've observed. So absolutely.
Yes. And then next, I think airway. I think either airway or vasculature is probably our most
nerve-wracking.
our most important difference between the pediatric and a more adult population.
Yes.
So I'll kind of let you run with this because you see it in the real world.
Yes. And so pre-hospital, that is the when we walk on scene and we see a child that's struggling and that is having difficulty breathing, and then making that decision to commit to that airway and to take over that airway, or is the child able to maintain and handle that airway? And so depending on their age, depending on the vitals that I'm observing, their heart rate, because kids aren't going to have a sudden cardiac arrest. It's going to be the indicators that their airway and their respiratory status is failing and not working appropriately. And then it deteriorates quite rapidly once it starts to go downhill. And so having the confidence that you walk into the scene and knowing I need to intervene, and not being afraid of applying oxygen or high flow nasal cannula if you have those capabilities, and getting something administered to help out, and then decide if you do need to intubate and take over that airway. Your asthmatic patients, that kind of changes some things, because if they're able to maintain on their own, oftentimes you want them to keep maintaining and doing what they're doing. But if there's distress or narrowing or closing of the airway with any edema, like epiglottitis and croup, you just want to be very aware of things can hinge and go downhill quickly, where you may not be able to get a tube through those vocal cords. And so you see the infant on the far left there, where it's very floppy. The epiglottis is just, the tissue is a little bit floppier and looser. And so to be able to lift with that Miller blade and be able to get in and get a good visual of the vocal cords. And if there's any swelling or anything that's closing that airway off, I've seen epiglottitis deteriorating to where a surgical airway was required, and it can change where you recognize your patient is not doing well, and you wouldn't be able to pass a tube through any of the cords, because it's just not an intervention that you can perform at that time. And so good airway assessments, good listening to your patient. Do we have stridor? Is there high-pitched wheezing sound, or even just, doesn't have to be necessarily high pitch. I think that's misleading. Just kind of that wheezing sound where that increased work of breathing, and not to be afraid to apply oxygen, not to be afraid to put on oxygen and get that ball rolling, and breathing treatments if possible, if necessary. If you have that capability with your program, then doing things, because airway and respiratory status is going to be the key.
Yes.
It's going to be between creating a deteriorating patient rapidly if you don't intervene. So,
yeah, I strongly agree with you that, I mean, the mainline teaching for pediatrics is that they're healthy individuals who don't have heart problems. They don't have chronic medical illnesses like your adult patients do. So if they are having an emergency, it is most likely respiratory. And if that fails, all the dominoes fall.
Correct.
Now that, of course, a little asterisk, that is not taking into account those fragile medical patients who already have underlying illness. That's different. But for the mainstream pediatric population, they're healthy and well-formed and fully functional without, chronic problems, which is to a benefit for them.
Exactly.
You were talking about the epiglottis and epiglottitis, and you've had an epiglottitis. That's amazing.
Yeah.
So as a pediatrician, I have personally not seen epiglottitis, and I am practicing in the time of immunizations. And so most people are immunized.
Correct.
And Haemophilus influenza is the type of bacteria that is most common cause of bacterial epiglottitis.
Yep.
I think in the age of vaccines, now the more likely etiology of an epiglottitis would be an airway injury, like an inhalation or something like that.
Right.
So I think it would be fairly obvious if you're like at the scene of a fire or something that you're
Right.
in a different situation.
Exactly. And then most likely in that situation, we would take over the airway without even a hiccup. But it was definitely a moment where you think, no, this is no. And then it got to the point where the child was responding to oxygen. And then we were in the facility, and then the deterioration was just night and day. And then it was the discussion between providers and even the trauma surgeon. What do we do? And at that point, they had gotten the ear, nose, throat doctor on the way, because it was a little patient, and I think right about 2 years old or so. And it was one where he arrived, and they were talking about it. This gives me goosebumps because everybody was talking about what would be contraindicated, what would be okay for this child. And he looked right at this child and he said, death is contraindicated in children. And he just did it without even a pause. And so I thought, so when I have patients and I have little patients, I think death is contraindicated in my children and my patients. And so I'll do what it takes and to make sure I recognize early before that even becomes a thought that there could be a demise. And so it's, it's something that I hope I never see again.
No, what a scary situation. We're certainly taught that epiglottitis, if you're suspicious that your patient has epiglottitis because they're tripoding and drooling and and they're having high fevers and obviously ill, and we're taught not to, that is a child who should not be bothered. You should not be trying to look in their throat. Don't try to gag them. You're trying to just calm them down and transport them to a place where, if needed, you could go to the OR for a surgical
Exactly. Calm is the key. And that's why there was no IV. There was no thorough assessment like that. It was just to that point where you recognize we're going to tip off this tower pretty fast and it's going to deteriorate quickly. And when it did, it did.
Yeah. How scary. So the belly, I think I already mentioned a little bit that examination of the belly in pediatrics can be tricky, because if you're actually hurt, you might not be super duper compliant. It's not like in some age groups of pediatrics, you can't say my tummy hurts. This is obviously a picture of an infant, and the only sign you might get from an infant is they're not feeding right. Maybe they've vomited. They're not acting right.
Right.
Other things to call out, their organs are, close to the skin. So there is potential for harm, a non-external trauma situation. And there's not a lot of padding with fat and things like that. But as I mentioned earlier, if you practice just gently feeling the belly, you will start to feel what a normal belly feels like, even when the kid is crying.
Right.
And then you'll start to recognize, oh, this one's like really firm.
Absolutely.
Like a basketball.
Yep.
Vital signs. I think this chart is important to point out that normal vital signs in pediatrics vary based essentially on their age, and doesn't really matter your source. You should have a source on your phone or in your rig or in your mind or wherever you get information from, and you should know where it is and know to use it appropriately for different patients.
And then to know, too, what your parameters are for specific injuries, like traumatic head injuries and traumatic injuries overall. Do we less than 90 is unacceptable? I believe the standard is now. And so you want their systolic pressure greater at 90 or greater, and to know when to intervene and to not be afraid that you need to do something before the patient deteriorates. And so I guess that's the key. I'll keep rephrasing, is that intervene before deterioration occurs. And so it's necessary to catch something, because again, that compensation, their heart rate may be going up to maintain the blood pressure. And so it's compensating till they don't. And so catch it before they tip off the edge.
Yes. I'm sure that's true in all patients, but it feels like in pediatrics, like their edge is very steep.
Right. Absolutely. Very true.
Okay. Exam tips and tricks. Bribery. I don't know if bribery even works, but maybe.
Depending on the age group.
Yeah, depending on the age group.
What about as a parent? Maybe just as the parent.
I will say in the hospital, we are lucky to have child life. And certainly there's more than one kid that gets a little something out of the child life basket after they've held still for something.
Exactly. And that's just it. Because even watching your video screen, or sometimes I'll take my phone and find a cartoon that I'll have on it, and just being able to distract them with things along those lines too. And finding out what it is that's going to get them to be distracted. And so
I've certainly seen, moms pull up their favorite little show and people, they hold still for all sorts of things. Oh my
gosh, it is incredible.
It's like, I couldn't give you sedation medications that would work as well as that.
Exactly. I have kiddos sit through CT scans and not need any sedation because they're watching a video that they were interested in. So just know what their interests are and what you can use, what tools, and ask their parents what works best to distract them. So absolutely.
So head, obviously you guys know when you're assessing a scene, what you've been called for. There's going to be some sort of called for blank. It says you're assessing for bruising, normal versus abnormal. Yes, of course, that's true. But ultimately, if there's bruising around the head, you're going to be worried about that being the primary source of injury. And we can get into whether it's abnormal or normal later. We've already talked about the fontanelle. Moist mucous membranes, I just think that's a super easy, quick way to look at somebody's
wet
hydration.
tears, moist,
And then the good suck reflex in infants, babies who are feeling well and normal will get a good little latch and suck on your gloved pinky, and that's a natural reflex for them. If they feel absolutely awful or having some problem, then probably the parents are going to tell you they haven't been feeding all day.
Right.
And they are not going to be suckling on your gloved finger.
Yeah, that won't be a comfort that we can use. And so, and a lot of times on our scenes when we arrive, if it's a traumatic injury, a car accident, we won't necessarily have bruising, anything observable right away. So you wouldn't have the indicator of this is where the patient was struck. And so that's something to think about when we go on scene, is that even with your adult patients, it might not have bruising immediately, and so it doesn't have the obvious this is where we might be hurting kind of situation. So that's why head to toe, checking everything out on those little ones.
Yes, definitely. The mouth and the throat, we addressed just briefly about the epiglottitis. Are you really trying to gag a patient and see in their posterior pharynx in the field? There are some contraindications to doing that. Certainly if you're in a situation where a kid has just choked on something or whatever, I don't know, that's an in the field sort of thing.
Yeah, absolutely. The choking, the being able to take a peek in the mouth and throat. And so with most all of our patients, especially those respiratory patients or those airway patients where you're concerned, you definitely want to take a peek in the airway if you can. And sometimes if your child is screaming, you can see right down to the vocal cords and go, I could intubate that from here and just drop the tube in. And so it's fairly easy to get a good airway assessment on those little unhappy criers. But again, like we kind of mentioned with the epiglottitis, it's know when to hold back and to stand off, and when your diesel or your jet A fuel is going to be the best thing to offer that patient. Move fast to a definitive care where you've got surgeons and all the pediatricians and all the professionals lined up. Or do I need to intervene now? Do I need to do something now? Is there something obstructing the airway? Is there something oxygen demand that I need to, an intervention I need to perform? Be mindful of that and then do it. And that's the key for those patients. So.
And speaking of obstructed airways, this looks swollen, inflamed. I see pockets of pus in those tonsils. But the picture is there to remind me that developmentally, many children in their toddler and kind of preschool, like between 2 years and 5 to 6 years of age, have sort of enlarged tonsils at baseline. So that kid might be screaming, and you're looking back there at seeing these tonsils that are almost kissing in the center, and you're thinking, oh my gosh, what's wrong? And that's just how they are right then.
Yep.
And those are the kids that are snoring at night, and parents hear them, and that has nothing to do with what's going on.
Correct. And oftentimes that's when I look over at the parent and go, are you aware of what I'm observing, and is this familiar with you? And if the parent's like, oh yes, okay, and maybe they forgot to tell you on scene or something, and then you can kind of step back and think, okay, I can stand down from this for a second and make sure this doesn't get any worse. But I'm usually looking at the mom or the dad and like, is this normal?
Yes. So this particular picture, I think if the parents were like, yes, little Johnny's had a fever and hasn't had anything to eat in 2 days, and you're looking at that, you're like, oh, he has a sore throat.
Yep.
But back to the respiratory system, I think it's, you guys know signs of respiratory distress, nasal flaring, grunting. I think of those as kind of more moderate to severe signs that the baby is working quite hard. And as you've been saying all along, that's something I would think needs intervention, not just observation.
Yeah. And as I know, when you walk into a room or if we walk onto a scene and you see that little one with the retractions and the nasal flaring, and yes, when I see that, instantly goosebumps go up on my arms because I think, oh, this little one's struggling, and how long have they been struggling, and when is it going to be a moment where there's no turning back from? And so it's all the signs. They're giving you all the signs that there's problems, and so you're there to help after that point.
And at this age in this picture, it's obviously more of an infant. Their chest walls are very compliant. If you think back to our bone system that we already talked about, you just got born through a birth canal, so you are more squishy. So their chests do move more in their respiratory distress. And as they are breathing faster and maybe doing that grunt is kind of like auto peep pressure for them. And then this picture is circling right below the ribs, but you can also see intercostal and supraclavicular retractions and kind of, I think in the older babies sometimes don't have enough necks to see that, but in an older, like an asthmatic or something, you might see that kind of in their neck muscles as well, using all those accessory muscles. Yeah. Half a neck right there. You might see some little quivering retractions there.
Oh.
Thanks, Sean.
I'm trying my hardest over here.
So moving from the respiratory to the cardiovascular, pulse checks. I know you guys know where to check for pulses. Arms are usually pretty available. As a pediatrician, I like to get down into the femoral pulses. And then there's a little comment to keep kiddos warm, obviously during compressions, but I would say at all times.
Yes, absolutely. I think that is the number one thing in the pre-hospital realm that is difficult for us, especially during this time of year, is I'll have a little tiny patient that I'm getting packaged and taking out to the helicopter, and it's freezing cold. And if the blades are still running on the helicopter, then we've got air blowing everywhere. And so it's just, I'm in this mode where the number one thing, once I've got the respiratory and ventilatory status where I know I have enough time to get to the helicopter, once that's stable and I can get to the helicopter, I'm just warm, covering that child up. And so I think that same thing, what I always say when you're in the back of your ground ambulance or in your helicopter is that you should be so uncomfortably hot. Nobody cares about how hot you are. It doesn't matter. You should be so uncomfortably hot. You are baking, because that means your patient, while you're assessing them, is just getting comfortable. And that's when we're in the helicopter, we are on fire. It is so hot. And I don't want to hear a peep out of anybody about how hot it is in that helicopter, because my priority is warmth on that patient. And I think the same thing goes when we're in the back of an ambulance. You should be sweating. You should be baking, because it's got to be warm for that patient. And so you can check the pulses and you can get an adequate skin assessment and get the rest of that full assessment going, because they need to be warm.
I do think this picture is obviously a little infant, and it is definitely true that physiologically in those infant months, normal babies should be able to regulate their own temperature, but they are more sensitive to strain. And temperature dysregulation is one of the first things to kind of go when they are critically ill.
Right.
And it can be either a fever, like we all know, oh, person's having a fever, they're sick. In a young infant, it can also be hypothermia as your signal of severe illness. So extremes either way.
Right.
make me very nervous as a pediatrician in this infant age group.
Yep, absolutely. And I know for a fact when I get nervous or when I'm out in the field, my hands get super cold. And then here I am repeatedly touching this little patient. And I'm just like, oh, got to get warm. We've got to get warm.
Sean, I don't know how to go back with this little clicker.
That one right there. Yep.
So we skipped over the diaper exam. Again, I think you're going to have some sort of clue why you were called to the scene. And if there's some sort of genital emergency, then you're obviously going to be looking under the diaper. I think this is kind of part of your first assessment.
Yeah.
Like
naked.
Yeah.
Yep, exactly. And especially there's an age group that has the sudden testicular pain, and then they're very uncomfortable talking to you about it. And then the family is also maybe a little bit nervous talking to you about it. And then I always reiterate, this is an emergency, a torsion. This is an emergency, and it's very important, that to get everybody educated about full assessments and especially on that last bullet there, the alleged abuse. If I'm suspecting something and I'm on scene and I'm working with a little infant and we're stable, and then I'll usually make the comment that I'm going to change their diaper because I think their diaper's wet, even if it's not. I'll do a diaper change and just tidy the patient up just to get a quick full check and just make sure that I've got that full assessment, that I'm not missing something, even if I suspect it in the back of my mind. I'll just like, hey, I'm going to just change diaper, get us all cleaned up before we head out. So
that makes sense.
Yeah.
Okay. So high yield concepts. I think we've kind of hit on the parents already. As we've mentioned, there are many reasons that parents can be distrustful of the system, but ultimately, in my many years of practice, I have found that most parents want the best for their children, and I want the best for their children. We don't always agree what the best is, but if we can find common ground of let's make a decision together to do the best thing for your kid, we can usually move forward together. So I would work towards that. Milestones. This is a little bit like a vital signs chart. There are charts out there. Please be aware in pediatrics that developmental milestones exist. They are ranges. So everybody is going to know a kid who walked really early and they were walking and cruising by 7 months. And everybody's going to know a kid who is at their pediatrician's office and really stressed out and worried because it's 15 months and they haven't walked. And guess what? Both of those kids are going to college and totally normal.
Yeah, exactly.
So regardless of what you're talking about, there's a range.
I always joke that the patients didn't read the manual, and that goes for all age groups. And so they didn't read the same handbook that I was given to study them. And so sometimes they don't fit into that category, but just use your common sense. And that's the big one. And the obvious things, like if you have a patient that's not ambulatory, not even rolling yet, you're tiny patients, and that somehow the report that they rolled off the bed and you know that they haven't been able to roll, or they're not in that phase yet of their life, just kind of little things like that when you're bringing the patient in, make sure you include that in your report, that there might be something unique to how that injury occurred because it doesn't match up with a typical milestone. And so
in pediatrics, we teach if you don't cruise, you don't bruise. And that is definitely true.
Very good.
Bruising in a non-mobile child is not normal, unless it has a perfect story. Yes, that really matters.
Absolutely. That's just it. That's a very good saying. So
the other thing that I think this matters for you guys is when you are working to interact with kids, you're not going to ask a 9-month-old, how old are you? But you can play peekaboo with them, but you're not going to play peekaboo with a 16-year-old. So that's the other place where milestones matter, and think to yourself, who am I dealing with? The other place this is a little tricky is sometimes if you have a child who is maybe physically more or less mature than their developmental age, you might need to be interacting with them differently than they look. Again, defer back to your parents of like,
what age appropriate responses do they engage in, and or maybe they look or they have the developmental features of somebody older, but they're still in the mental capacity of a 6 or 7-year-old, and so
maybe they're even nonverbal.
Exactly, correct, exactly. And so again, rely on your parents too.
Sure. This is another kind of maybe mental thing that's easy to remember.
Right.
If you have a chart of vital signs that you're referring to, this is hopefully just supporting in an easy way to remember kind of those like hard line, normal, abnormal.
Yes, that this is not okay, and this is the hinge where things start to go poorly, especially in that pulse of 60 beats a minute. There are quite a few of us in the pre-hospital realm that you see an infant that has a heartbeat of 60 beats a minute, and you're in that adult mode where you think, okay, we've still got a pulse. No, it's not okay. This is not. You need to start CPR and be brave enough to start CPR to save that little patient's life. And because it needs to be done. It has to be done to ensure that they don't have a complete arrest and that you can catch them before you can't bring them back. And so knowing those abnormals, because they're right on the hinge of being unable to bring them back.
Wise words. Let's see. So I would say this is timely if you're listening to this right now, because we're headed into the respiratory season. There will be lots and lots of infectious stuff going on. So lots of reported fevers right now. In pediatrics, I consider a fever 100.4 or greater. Core body temperature. And we say that because there are many ways to take a temperature now, like temporal and under the armpit and all these other things. But I'm really not interested in doing a huge workup or even really worrying about it at all until we have a core temperature of 100.4 or more, which is 38 degrees Celsius if you're in Celsius instead of Fahrenheit. And the other thing about fevers is, to me, they're just a sign that something is going on. It's not inherently harmful to you.
Right.
I don't know really where this came from, but there is, well, actually, maybe I do. There is some concern that like, oh, I get asked a lot by parents, is this fever going to hurt my baby? And I'm like, nope, it's not. It's going to help your baby's immune system get going. But fevers are easily identified by families. You can give Tylenol to them, so they're a pretty common thing to talk about with families.
Yes. And it's just good that they're mindful and aware of it too, that they care enough that they've taken a temperature and that they have awareness of that fever. But it is kind of a natural way for their body to trigger that response to get them towards healing. So
the other thing that I think is important to know about fevers is that nobody feels good or looks well when you're having a high fever.
No.
And so if you arrive on scene and a kid is tachycardic and tachypnic and has a fever of 39 degrees, and, sometimes if you give them a dose of Tylenol, by the time you get to the ER is like, I don't understand what you're even worried about. They look so much better.
Yeah, just that change. And so a lot of families are even afraid to give Tylenol or ibuprofen, and alternating. They don't have that comfort level with it too. And so they'll call and have pre-hospital arrive. And sometimes you can fix those or make them look better before you even bring them in too. And so, because they do look scary. And then like this slide addresses the febrile seizures look very scary. And for a parent that's never experienced that before, you can definitely understand how that's a traumatic thing.
Yes. And febrile seizures are a pediatric thing. The brain is very rapidly developing between about 6 months of age and 5 to 6 years old. And so that's when the pediatric brain is more susceptible to having seizures. So I try to teach my parents that all brains will seize if put under enough stress. You've already mentioned check a blood sugar. If your blood sugar is only 20, I promise you your brain is under stress and might have a seizure because of hypoglycemia.
Absolutely.
There's a genetic predisposition to febrile seizures. And so if you're genetically predisposed and you are in this age group, you might have a seizure as you're doing, and it's not necessarily the height of the fever. It's usually how fast.
I was just going to ask you, is that the thing, how fast it goes up? And so,
again, because that's stressful to have.
Yep. Your body can't compensate and kind of gradually get used to it. And I sometimes call it the Control Alt Delete for the body, where your body just reboots and then resets itself. And so it's kind of a layman term for kind of a scary situation, but it's your body just resetting itself.
Yes. And so in pediatrics, if a parent is paying attention to their child, I imagine that you're getting calls all the time for a febrile seizure in a kid who is an undiagnosed.
Right.
I think once a family has been through it and they're like, oh yeah, my kid has febrile seizures, then you might not be getting
night and day difference. Yeah.
Most febrile seizures self-resolve within a matter of minutes.
Yep.
You can get complex febrile seizures, which kind of go on and on.
Yes.
That's different. And we would kind of work that patient up differently once they get to the hospital and think about them slightly differently. But for the most part, simple febrile seizures are benign and hard and scary to watch, but not harmful to the kiddo.
And you can tell the difference between parents who have their very first febrile seizure versus the parents who are this is their third febrile seizure they've had in their lifetime so far. And so that's a different level of calm or understanding of the situation.
Yes, for sure. So then respiratory season, bronchiolitis. This is an interesting slide. So bronchiolitis is what is bronchiolitis? Bronchiolitis only happens in children. In the United States, it happens in children who are less than 2 years of age. In Europe, it happens in children who are less than 1 year of age, which just means they've defined it differently when they study it.
Exactly. Different parameters.
Yeah. So the picture on the right is showing, so the reason it only happens in small children is because the size of the bronchioles is smaller in a 1-year-old child than it is in a 10-year-old child. So when 10-year-old kids or adults get RSV virus, they feel like they have a head cold. There's swelling, there's mucus production, they feel crummy, but it doesn't really cause swelling and blockage of their bronchioles.
Right.
But when your bronchioles in the kind of end of your airway, when those are filled with mucus and swollen and you can't move that mucus out, I mean, a 2-month-old can't cough up a loogie. And so that mucus is just stuck in their airways, and that is hard to breathe around. And so they are breathing fast and breathing hard to try to overcome that blockage. And so you see bronchiolitis during the viral respiratory season, and it is a very frustrating illness. RSV gets blamed for it, but the truth is that many respiratory viruses can cause these symptoms, and it affects the younger kiddos. The best way to protect young kids from getting this is to prevent their family members from bringing germs home to them.
Right, exactly. Hand washing, keeping the germs out. And absolutely. And again, pre-hospital, that we are not going to be able to have the diagnosis for this, but get the clues from the family. Have we had a recent cold-like symptoms? Have we kind of been feeling under the weather for the last few days? Has it deteriorated and traveled a little bit more into their lungs? Then you can get that idea. Okay, maybe it is the bronchiolitis. And then what do we do in the field? They need oxygen. That's all the studies and all the research show that. I think it's still the common thought that oxygen, suctioning of the airway, but oxygen, is going to be the key. And so, especially if they're the obligate nose breathers still, that you need that nose to be clear, because how are you going to get the oxygen in there? And so it's two key things that we need to do, and that we should be comfortable doing to those little patients, because that's going to keep them from deteriorating. So
yeah, the nasal suctioning cannot be overstated. And, certainly upon arrival on scene and assessment, and if you can get their noses sucked out and pop them on oxygen, again, by the time you arrive to wherever you're going, you might have a completely different kiddo. in the hospital setting, when somebody gets admitted, we need to then be cautious that we're regulating our nasal suctioning so that they're not getting suctioned every 10 minutes and all of a sudden they're getting more nasal trauma.
Yes.
But so we then try to do it maybe before a feeding to really kind of clear out their nasal passages. Or if they get themselves worked up and breathing too hard, that's a good time to intervene and suck the snot out.
Absolutely. Because if you do it too much, then you cause some inflammation and swelling in the nares. And that could have a detrimental effect too. And so just being super mindful and clearing out what you can, and even using a little bit of saline or the mucose, the device that aerosolizes medication that we use that you can put on a syringe. You can moisten that and put that up there and kind of get some of those little boogers softened up, and then try to suction it out. Use little tips to soften it up first, little saline drops in there to soften it up before you suction out. That helps too. So just getting it out.
There's a lot of good articles that look at those little mushroom bulb things that kind of stick right there in the nostril.
I think we call them MAD, and I can't remember what.
Sorry to jump in and interrupt, but all successful podcasts have advertisements. This podcast wouldn't exist without EMSconnect, an online, self-paced CE platform for all levels of EMS providers and firefighters. Our site houses over 140 hours of nationally accredited content for all levels of EMS. Access to our site is only $7.50 a month. There are no join fees, cancellation fees, and definitely no bullshit. We also host monthly live sessions where you have the option to interact with our talented and engaging instructors. Just for listening, you will be automatically entered to win a $50 Amazon gift card, which will be drawn at the conclusion of each of our live sessions. All of our courses we offer can be easily imported to your NREMT profile with a few simple clicks. This greatly simplifies your recertification process. All of this can be yours for only $7.50 per month. In this economy, we're spending more than that on our daily coffees. But wait, there's more. Our site also offers EMT, advanced EMT, and paramedic level NREMT refresher courses that are 100% online and self-paced. For all of your training officers out there, we make your job super easy with our administrative tools such as uploading agency courses, skills tracking, participation reports, and so much more. To get a no-catch peek at the administrative tools and capabilities of EMSconnect, contact us at info@emsconnect.org. Again, info@emsconnect.org. All right, enough of the advertisements. Let's get back to this great episode.
Exactly.
Metered atomizer.
Look at you.
Device.
Perfect. I know the last word's device.
Yeah.
But I was thinking, those are fantastic because we think of those as for our Narcan administration, our adult, medicines that we give intranasally when they can't, when we need rapid administration without doing an IV. But those are fantastic for your little boogery kids that need the nasal suctioning. Yeah. Absolutely.
Definitely. Asthma, you've mentioned a few times. Asthma, I'm sad to say, can be a life-threatening respiratory situation. So you absolutely could get called and arrive on scene where a kid is 100% not able to breathe. And again, usually it's going to be a known asthmatic who's been kind of going down the tubes.
Deteriorating,
for the last day or two, despite using their inhaler more frequently. And you did say something earlier that I was going to mention. Oh, yeah. You talked about, you get there, you're listening, you're hearing lots of wheezes. I agree that is abnormal and bad, but the worst asthmatic you can get is when you're not hearing any air movement whatsoever.
Correct.
That's even more scary than the wheezes. Ideally, you want to move the needle completely the other way so you're hearing good air movement without wheezes.
Right.
But no air movement in an asthmatic is bad.
Because it's them not getting the air out. Correct. They're having trouble necessarily. That's a restriction getting the air out too. And so they're trapping that air in, and then there's no gas exchange, and then you have a CO2 buildup and all that clinical pathway that adds to that poor asthmatic. So for pre-hospital, we have it kind of taught to us and instilled in us that don't intubate your asthmatic patient. Let them tripod, let them sit how they want to, get them to the hospital. And so it becomes this nerve-wracking thing with that thought process, switching gears, that we might need to intubate the asthmatic. And the key with that, and I think you can add to this, is that if they need to be intubated, intubate it. Because I think as pre-hospital, what's nerve-wracking is that you show up and we arrive in your ED and then we say, we intubated this asthmatic kid. And then you think, please don't be mad at me. And so just knowing that it was needed, you have to do it. And so they need to have good gas exchange. And so it has to be done, even though it's taught so often, don't intubate the asthmatic kid. It's sometimes you have to, just to save their lives.
Yeah.
Death is contraindicated.
Death is contraindicated. These are just pictures of asthma. Obviously, all the way over on the right-hand side, the airway is swollen and there is mucus production as well because it's all inflamed in there. And you just have to really work hard to open up those airways again. Head injuries. I mean, I think you guys know exactly what a head injury and concussion looks like. I don't think it's that different in peds and adults. It's the same.
Yep.
And concussion management. This slide is more of like my concussion management. This is after they've been at the hospital. We know what's happened to them. And this is kind of the counseling that families get. Return to play. Many of the concussion kids that we're dealing with are athletes. And so then they are kind of having a strict return to their normal activities. But obviously kids fall off their bike when they're riding without a helmet, or, are also in situations where they have concussions, even though they're not old enough to be in organized sports. And so it's counseling families that they might be more irritable. They might nap when they don't normally take naps.
Right.
Their brain needs to recover and recover from their injury.
And if we come on scene to somebody that has had a head injury, and it's good to get information from family, has there also been an additional, is this a repeat head injury? Is there something, a repeat strike of the head? And so there could be something underlying that's building and worsening. And so it's good to get that kind of history from the family as well. If we do come on a scene call with a head injury, is it a repeat one?
Definitely. That's true. There is seasonality to pediatrics and spring. Yeah, this is definitely true. Allergies, asthma. Some kids always kind of spike up because whatever they're allergic to is pollinating or whatever it's doing in the springtime. In the summer, definitely teenagers are out doing things that they shouldn't be doing and getting in trouble doing it.
Yes.
For the younger kids, I think that's where we have the accidental or near drownings. And enterovirus is thrown up there because it kind of classically causes problems for us in the summer. And it's a little unusual to be a summer virus instead of a winter virus.
Yeah.
Tick paralysis, I think, is a fascinating problem that magically gets better when you find the tick and remove it.
Right.
So that's pretty cool. In the autumn, this is definitely true. You've been away from your classmates. Now you're back in school. You're sharing all your germs and starting to have snotty noses and respiratory problems again. And then in those older teenagers, there's stress as they go back to school. And so teenagers or older kids are doing suicidal gestures.
It is quite frightening how many kids we transport that have had suicidal attempts.
Yes.
And with full gusto and intent to follow through with it. And it is absolutely nerve-wracking. And those are the patients too that I find that when I do get them alone and can visit with them, and once we're away from the stressors, and sometimes being in the ambulance or being in the helicopter is a little bit peaceful because it can be just me and that patient kind of trying to bond and get a connection of what's going on and connect. And so if you have a patient that you can spark a change with or connect with and make a bridge and offer hope, any little words can help out. Because I've had quite a few teenage girls that I've transported, and I can say, I was, I never had despair along that lines, but I didn't graduate from high school at the top of my class. I didn't have any ambition or goals or know what I wanted to do. And it was all overwhelming and confusing. And so, trust me, I was there, but life can change. And so to be that spark of hope when you do have those suicide attempts, don't just rush and not communicate or not talk with them. because you could be the person that changes their life. So
I do think being alone in a flight or an ambulance, it might be very peaceful for them. Many of the kids do talk about the influence of like social media. I mean, you're not on your phone texting as you're on your live flight or whatever it is you're doing. And so that firm break for a real reason can be very liberating for them. The other thing, and this is honestly one of the reasons that I went into pediatrics and that I love pediatrics, is that you have to remember developmentally, teenagers are kind of emotional little wrecks. Like nobody blames a 2-year-old for having a temper tantrum, right? Yeah. Everybody's like, oh, it's the terrible twos. The same is true for those teenage years. Your hormones are going crazy. You have real life fears, but your frontal lobe hasn't developed enough to manage those and self-regulate those things. And just like learning to take steps and walk, you also have to learn those kind of mental skills,
mechanisms to control them.
And so I find that when I can frame these patients like that, like they are acting developmentally appropriate. They are overwhelmed by their life experience and don't have the mental capacity to help themselves. Right. But I can work to engage with them and reassure them that this is normal.
Right. Right.
They are normal.
Yep.
And they will be okay.
And they will be okay. It's a phase, and they can pull through that. They can work through that. Absolutely. And reassuring their family too. And that's where you are a key player in that, is reassuring family. It's just one step at a time, one day at a time.
Because, and I do think maybe it's more common, or maybe more people know about it now, which is good. We should talk about mental illness. But I think until it happens to you or someone in your family, it's like this very vague notion. And then all of a sudden you're like in it for real. Yep. And that's very scary for many families.
Because sometimes you don't want to have it addressed right in front of you. And then until it happens, then it becomes very real. Absolutely.
Yeah. And then it's viral season, folks. Wash your hands.
Yep. Wash your hands.
Red flags in pediatrics. So I personally think that these things in this bullet list, this is what practically all parents say to me as I do my history and physical in the hospital. Little Johnny hasn't eaten for 2 days. Normally they're running around like a crazy wild man. They've been laying on the couch. They haven't peed all day. I haven't changed a wet diaper all day. This writes itself. Yep. This is what sick kids look like.
Yep, exactly. Yep. All the bullets are ticked there for when you have one that's not doing well.
Yeah.
And then it's your job. They bring them into you. We bring them into you. And then you figure out what is going on.
What's making all this happen?
I mean, to be fair, though, most adults, I would say when they don't feel good. That list is pretty much the same thing, right? Like, I don't want to do anything. I really don't feel like eating. I really don't feel like drinking. I don't like going to work.
Nope, exactly.
I think where maybe medical providers get scared about kids is, you're right. Adults do feel the same way when they're sick, but they say, my head is killing me and I'm nauseous.
Yep.
Whereas a kid doesn't say that until they like exorcism vomit all over the mom, and then like, and so you kind of feel like you're confused as to what could be going on,
right?
But it's very obvious they're sick and not feeling like themselves.
Yep.
So in pediatrics, we take fevers in 0 to 3 is true, but as in all things of pediatrics, there is a scale, there's a development. So if you are less than 1 week of age and have a fever versus 1 month of age and have a fever versus 3 months of age, you might be on a slightly different protocol as far as the workup and treatment you get, like automatically. Really what this comes down to is the immune system of a newborn infant is not as mature as it will be in 2 months, and in 4 months, and in 12 months.
Right.
You've never met any germ before when you are 3 days old. So that is why children in this age range get a more thorough medical evaluation compared to like the 7-year-old who comes in with a fever. They're like, why are you even here? Give Tylenol and come back in several days.
Exactly. Yes. Yep.
So it's just a different population.
Yep. And to make sure too, probably that there's nothing going on that could be even congenital or something, what's the word I'm thinking of, where
well, we do have inherited like metabolic problems or even immune system, like you have a faulty immune system.
Right.
And you don't know that until you discover it.
Right. And so, and here's the time when the clues are there. And so you definitely want to research and make sure nothing gets missed until it becomes something tragic. Absolutely.
Lethargy. This is like a little buzzword for me. Again, that the bullets we just did back here. This is what all parents say to me when they tell me why they are here today. There's probably a 50-50 chance that in that conversation, they say, little Johnny's lethargic. And when I think of lethargic, I think everybody get in this room right now because we're like pre-coding. Like, does this kid have an IV? Do we have the oxygen?
Exactly.
Like we are in an emergency. When most parents use this word, they're saying little Johnny's been moping around on the couch and is not running around and bothering his siblings. You guys are medical professionals. I think when you use the word lethargy, it should mean I was really scared in the field. This kid was ill.
Did not care that I was trying to start an IV. That's my big one.
Scary.
Did not. That's when I'm just like, we're lethargic. I need help. That's usually the big one when they just lay there and I'm starting an IV and they don't even move. Yes. Oh my word. That's when it's like, okay, we got to move fast. We're not going to dawdle. We got to go because this is not good.
Yes. And then the other time that I, even as a medical professional, struggle with this word is, when I was on call last night and a kid came in at 3 a.m. and they were, hard to wake up at 3 a.m. Is that because they're lethargic or is it because it's 3 a.m. and it's bedtime?
Right.
And a 3 a.m. admission has probably started in a different emergency department as early as like 9 a.m. the previous morning. I mean, they could have been in the ER, not getting transported.
And they've
been kept NPO for all this time. So, lethargy in my mind is a very serious word, but it does get used by the lay population a lot. And then you just kind of have to follow up with your objective findings. What are the vitals? Right. What's the actual exam? And go on from there. In the pediatric world, we do think about abusive trauma, mostly because if a child can't speak for themselves, it's our job as mandatory reporters to speak for them. We're looking for a variety of things. I would say the first thing is, does the mechanism, if you are seeing something and it can be described in a way that it makes sense of how this injury occurred, that's very reassuring. If the story doesn't make sense for the injury that you can physically see, if the story changes over time, like you hear one story, the ER hears a different story, I hear a slightly different third story, that's concerning. And then I've already said if you don't cruise, you don't bruise adage. That's definitely true. But bruising in abnormal places, I consider normal places for bruising bony places.
Right.
And developmentally, if you're learning to walk and you fall down all the time, you're going to have some bruises on your knees and your shins and quite frankly, your head when you take a header into the coffee table. That's normal. And it should go with the story. I mean, these are children who are learning to move around. They usually aren't out of sight of their caregiver. I mean, a room away kind of thing. I heard a big thump. Should be part of the story. Not like little Johnny was nowhere to be found and came limping back with a broken something.
Unobserved. And, absolutely.
There's got to be some sort of story involved. But abnormal places would be soft places, like the belly should never be bruised. In an infant, like the frenulum or, bleeding or whatever inside the mouth would be very abnormal. And then I think we have some pictures then of patterned bruises, bite marks, linear,
And pattern bruising, what you said is perfect. If it looks like a pattern or repetitive area of strike, instantly should be unaware. Yeah, exactly.
Cigarette burns would also, I think, be pathognomonic for this problem. So again, actually that ear one, I do like that. And I am going to share a little story. So this is, in some ways I would say it's pathognomonic, and it's a very common injury if, kids are being grabbed by their ears and kind of like twisted or whatever. Not normal. But I personally have a child who, at the age of whatever, young, was in flip-flops and climbing on rocks while we were camping and slipped and crashed and hit her head right there against her ear. And she had a perfect linear bruise right there on her pinna. And I thought to myself, oh my gosh, like I have a pathognomonic bruise on my kid. But the truth is, I had a perfect story witnessed by myself, my husband, and my parents. We all watched her climb around on the rocks in flip-flops and fall. But you do look for ear bruises, and you do kind of flip their ears or their pinna kind of forward to look behind there as well. Like a slap upside the head or a twist of the ear will bruise in that location.
And how people react when they tell the story. If it was a care provider that fell or tripped and stumbled with the infant and they're there telling you the story, you can obviously see that what was an accident versus what was not. And is it still a common thing to do a pan scan on kiddos?
That would be standard operating procedure so if a child can't say what happened to them, it's our job to make sure nothing else happened to them. And that can be an abusive situation, or in a kid who, somebody's walking down the steps and trips and falls. They may recognize that there's a broken arm, but they also might have a broken whatever. And the kid isn't saying, this hurts and my hip. They're not saying anything. They're just crying and uncomfortable. And so it is important to identify all the locations of
perfect. So injury. They do get a head to toe pan. They call it a pan scan, a head to toe scan. So perfect.
Well, I don't think that's a very happy talk.
No, that's a terrible way to end. That's terrible. Who planned that?
If you do want more information on this topic, please use this QR code to the podcast.
He's a forensic investigator. So just EMS recognition of child abuse, neglect, human trafficking, things like that. So that will take you right to just the Spotify. If you don't have Spotify, that's fine. You can find us on any platform. This isn't a plug. It's more or less of, you want some more education, by all means. I mean, it's not a topic that's widely taught in initial education programs. So I think it's a good topic. We're likely to see it. Whether we recognize it, that's the question, right?
My partner did a really good grand rounds a year or so ago and talked about sentinel injuries and the importance of recognizing sentinel injuries. A sentinel injury is that, bruise on the ear, maybe, where you're at your pediatrician's office for your 5-year well checkup or whatever, and somebody sees that. And if that gets ignored, and that's an abusive injury, abuse is something that only continues and escalates. It's not something that happens once and never happens again. And so the more educated and comfortable you can be in your own skills of saying, that's not normal, even if it's not your place or your responsibility to investigate what it was, you recognize it as abnormal, you call it in as a mandatory report to CPS, and it could be that you're the first person to call and they make a record of it and nothing ever happens. And it could be that you're the 20th person to call. And then there is enough there to get a proper investigation and get a different outcome for that child. So the recognition of a sentinel injury cannot be understated. And in the hospital setting, we do see some of these kids retrospectively. We see them come in, horribly abused with subdural hematomas, seizing, like clearly damaged. And if you look back, like 3 or 4 months ago, they were seen in the ER for vomiting and, and you're just like
hindsight.
Oh, yeah. And it is hindsight.
Yep.
But if you do listen to a podcast like this and can recognize those kind of pathognomonic or warning signs of abuse, of trauma, you could actually make a difference in a kid's future.
Absolutely. And it's not a scary thing. As a pre-hospital person coming into a facility, I know our larger facilities here are so good at social service, taking note and notations on what's going on and taking a report and getting an idea of what was going on. And so it's not difficult on our end to make a big difference for that child.
Definitely true.
Sweet. Well, I just had a couple of questions. Yeah, that I just, here we go. Ready? No, I'm just kidding. Use of the stethoscope, right? Like you guys talk about listening to lung sounds. Well, as a provider who maybe doesn't listen to a lot of pediatric lung sounds, I think of, okay, my 4 spots, I normally listen to an adult. Is that the same as a child? Am I using one side of the stethoscope? Am I using the other side of the, like, just talk me through what should an EMT know about the use of a stethoscope, how to use it appropriately in babies and pediatrics?
I'm assuming you do you have different size stethoscopes?
Yeah, depending on the provider, they do have the small bells.
Yeah, and I think, if an ambulance company is buying 100 stethoscopes to provide their ambulance with or fire department, it's going to be a $15 stethoscope. That's probably not great. But I know some providers who go out and spend money, their own money, on a Littman, not that we endorse that company specifically, but whatever other company where you might have, the bell versus the diaphragm versus a smaller, so just some broad knowledge about that stethoscope and how to use it in pediatrics.
So if you are working with your agency provided $15 stethoscope, which is quite frankly what I work with at the hospital as well, unless I go back to my office and grab my stethoscope and take it in with me. You can get your gut exam with your diaphragm. I think it's important to recognize that the chest of a 1-month-old infant, you can listen on the right and the left, and you can probably hear the same stuff in both places because it's so small.
Right.
Different than a very large adult, where you're actually in a different listening post.
Okay.
I think probably for someone who doesn't listen to pediatrics a lot, I think maybe the hardest thing is going to be to listen to the fast heartbeat and hear it as the heartbeat and separate it from the lungs. To train residents and stuff, I say you have to listen out here at the lungs, like, bases where the heart really isn't.
Right.
And hear the lung sounds and hear what they sound like. And then when you put your stethoscope kind of on the chest wall where you can also hear heart sounds, you can kind of filter out those respiratory sounds so you can just hear the fast heart rate. The normal heart rate still sounds fast for those of you who listen to adults.
But it's a symphony of sounds when you listen to a pediatric chest wall. It's just, the cardiac sounds, the lung sounds. It's just a symphony of sounds.
And the upper airway.
And the upper airway. And then categorizing it in your brain to fit and to know what sounds normal and what doesn't sound normal. It's hard.
And if I'm listening down in the lungs, especially on like maybe a neuro kid who's bad, like they don't manage their secretions well, or a trach kid or something, I'm listening in the lungs and I'm hearing sounds that I know are respiratory, but I'm suspicious that it's kind of maybe like transmitted upper airway. You can listen over like the neck to the trachea sounds, or even kind of up here, and just hear what those upper airway sounds sound like. And then when you listen back in the lungs, you're like, oh yeah, all that is just like from
up above,
upper airway area.
Sweet. So my next one is IV versus IO, right? When I taught, or when I learned advanced EMT skills, it was okay. Well, interosseous is a great tool for pediatrics. The IV stick is a little bit harder. You mentioned assessing friends and family with permission about, chubby hands, things like that. Is there a time when you look at a kid and just say, I'm going to skip the problems that I know I'm going to encounter with an IV access and just go straight to interosseous? Or if I am going to pick IV, you learn scalp veins, you learn feet veins, you learn, like, is there a preferred location? Just kind of talk through that.
Well, I don't place IVs, so I would say the IV or IO access that you need is the one that the patient needs.
Perfect.
Absolutely. So it's my dividing line is how much time do I have to waste on looking for a vein versus I know exactly where to go with my IO. So if the kid's crumping, I don't even get out my IV bag. But if it's a situation where I think, okay, I need a little fluid bolus, there's a few things I need to do before we get to the bad situation here. So I'm just going to look for a vein. And in kiddos, you can do a scalp vein. You can insert. Remember, the point of your needle always goes towards your heart, no matter where you're poking. And so, the forehead or off to the side, you'll be going down towards the heart. And little tip that the scalp veins aren't valvular. They don't have valves that can help distribute perhaps any small pockets of air that you might have in your syringe. No air can go into those little scalp veins. Be very, very careful with those. But hand veins are good on our kids. Your tourniquet is going to be a key there. So often placing a tourniquet, sometimes 2 tourniquets, more in the upper arm and then on the forearm to get that backup of pressure. And then cutting your tourniquet in half. If you have a very wide adult size tourniquet, making it a little bit more narrower. So it's got a little bit more pinch into the skin. And so a little bit upper, a little bit lower, get that backflow of pressure in those hands. And you can usually get a good vein to pop up in the hands. And then and when you're placing a tourniquet on the head, I don't know how they do it in the hospital mostly, but you can sometimes do a rubber band or a little tourniquet just right above the eyebrows and get that vein to bulge up. And the saphenous vein, the vein that's on the inside of their leg, just right above their ankle, usually that one you can get chubbied up pretty good and get a visual. Sometimes you'll see them, but you won't be able to palpate them. You'll see that blue, you'll see it, but it won't be like the pressure in an adult where you're going to have that backup flow of pressure where you palpate and you're like, here we go, I can put this in here. You're going to see with your alcohol wipe, you'll wipe and you'll see a little blue line and you're like, okay, this is what I'm doing. I'm going to go here. And so don't forget the legs, especially on the inner side of the calf. That's often a good spot too, or on the foot. And then sometimes I cheat. And if I arrive on scene and I've already had a crew there that's taken a blood pressure in the back of an ambulance on the kiddo, I take off that blood pressure cuff because it's been squeezed and warm. And then I go and look under that blood pressure cuff and see what has been just being worked on before I even got there, what veins getting plumped up there. But yeah, IVs, that's kind of a kicker. If you're going to ask me what I think is harder is IVs or intubating a kiddo, I'm going to tell you an IV. It's just the one thing where I think, okay, this is it's just there's so many variables that you're working with, that the unseen with that vein that's going to be hard to grab and get. So, but you've got one tube to strike and hit when you have the airway.
So I'm in a different medical setting in the hospital. Things are much more controlled in some ways. And, when kids arrive having had an IO or maybe on exam, you're like, oh, I see these like little petechial marks from all the tourniquets.
Yes.
I think that's a sign like this kid looked ill. Somebody was worried about this kid.
Yeah.
And I think the important thing is that on scene, you are acting in a way that is supportive of your patient.
Right.
Giving them what they need when they need it. And we'll sort things out once you get them transported.
And sometimes that's not starting an IV or an IO. I have transported several times kiddos that I think, okay, the trauma, the stability level versus the trauma that I would initiate by trying to start a line right now. I think we can fly or we can transport the 13 minutes and get them to a calm, warm environment with a lot of distractions that's less scary. And so sometimes not starting an IV on your stable-ish patients that just need to get to a definitive care can be the best thing you can do. And so, and I might be wrong on that. I just think,
especially if you're talking about a respiratory kid.
Yeah. It's one of those where oxygen.
Always need IV
right. Exactly. And so you need to do different interventions and go and don't dawdle and go. And so,
Well, it's we didn't even plan this. Perfect segue, because my next question was the use of a cervical collar. So you have a kid who an adult would match realistic criteria for a C-collar.
Mm-hmm.
But you got to put a pediatric C-collar in this kid, and he's now thrashing around, he's yelling, screaming, and there's that thought of, well, am I going to cause more damage to this kid by forcibly holding his head still, putting him in a C-collar? So like, at what point is it, well, if I can just sit him on a stretcher safely and put some pad on either side of the car seat and put a cartoon in front of him and he will hold his head straight, is that a perfectly acceptable management technique? Then, well, my normal protocol says this kid belongs to be in a C-collar. I mean, is that acceptable? At what point is what you think you need to be done is going to cause more damage or create more complications than if we just don't, quote unquote, manage like we should?
Right. And I was just going to say, that is perfect, because my number one key is my patient and doing the best for my patient and still trying to follow all my protocols and guidelines. And that being said, you can do more harm sometimes by trying that IV attempt, by trying to place that cervical collar. And I've found that I have minimally placed pediatric cervical collars, but I have very frequently towel wrapped and put towels on each side. And then sometimes without the child even aware of it, you can put a washcloth folded over across their forehead and then gently tape. So there's no suddenly leaning forward. So there's things that maybe the equipment is not utilized, but you're still performing the same intervention cautiously, because you don't want to create that intracranial pressure. If you get them screaming and crying and you just think, oh my gosh, I just need them to not have an increased ICP, then you got to be mindful of what interventions you do. Even with your adult patients, same story with your adult patients is sometimes trying to check the box of what your protocol says you have to do sometimes can cause some harm. And so you need to be aware of the situation and then explain it thoroughly to your provider. Okay, I was mindful of this. I was attempting this. This is what we observed. This is what we came up with, and go from there.
And I think that's the key. I think that protocols exist for a reason. I'm in the hospital, so I have different protocols than EMS protocols, but certainly we have protocols, but all protocols kind of start with the line of like, you have to use your clinical judgment. And so I think it's very, very important that if you do choose to go off protocol, it's documented in your, note that you're doing about, this is why I did what I did.
Right.
I'm aware that it is not per protocol, but these are my reasons.
Right.
And then I think that that is the appropriate way to address that situation.
Yep. And then explaining it all to the provider and painting that scene when you get to the hospital. This is what we had. This is what we dealt with. And even the attempts made of doing the protocol level care and then why you deviated from. And so, but explaining it and justifying, especially in your chart, is why you did something.
And I think documenting it is a very key piece of that, because not only does it help support what you did,
right,
it also then is a good way to look back. Part of all of medicine is case review and outcomes and, what happened with that kid. And, if you look back and you have a little more information about what happened with the patient, and you can then learn from that situation.
Right.
Was it the right decision to go off protocol, or should you have stuck to the protocol, and why? And then how do you kind of fold that into your clinical practice?
Exactly.
My last one is asking questions about the delivery of the child. Like, when should I no longer have to be asking mom, hey, obviously a 1-week-old baby, I'm going to be asking questions like, talking about the delivery, was anything abnormal, any complications? Yeah. At what point is kind of a general rule of thumb, I no longer really need that information?
So probably for you guys in the field, what matters is no longer relevant past about, a couple months of age, unless that baby was extremely premature. When does extreme prematurity no longer matter? I mean, years. I mean, those are kids that might have lung disease and have more fragile lungs at the age of 2 than all their other term classmates. So, past about 6 months, you can probably get away with just saying, hey, any complications around the time of delivery? And they might say, yes, gastroschisis repair. And, at least you have that.
Right.
But you're right. In that first month or two of life, you could have late onset GBS. And there's a lot more going on in that time frame of a few months. Beyond that, I think it's pretty much respiratory or major surgical things that would have happened in the neonatal period that are done.
Yeah. And you hit that perfectly. And oftentimes you'll find that the family is going to tell you right off the bat, we have lung issues because of.
Yes.
And so they're usually offering that up. And usually I won't even mention the birth and full term because they've already told me we're having a respiratory problem because. Okay.
Yeah.
Awesome.
I have one of my partners had a kid with gastroschisis, some sort of bowel resection in the neonatal period. And he was in college and had a bowel obstruction from adhesions of infancy. So in college, his birth history was relevant.
Right.
Right. Lifelong.
Yeah.
Exactly. Lifelong.
Awesome. Well, thank you both for joining us. We don't do a whole lot of pediatric talks. So I think you did the last OB talk.
Yeah.
We just kind of concentrated just on delivery. But thank you guys very much for coming. Yeah. Let's hope it's a snake.
Let's hope it's. I
got to find a way to work that in here somehow. I don't know how I'm going to do that, but it'll have to go in the title maybe somewhere.
That's it. I hate to cut you off, but this was just a sample of one of our live sessions from one of our amazing educators. If you'd like to join our monthly sessions for free, you can follow us on Facebook by searching EMSconnect.org and register for our next session. We give away an Amazon $50 gift card, and you're able to interact with our speakers in real time. If you'd like to get CE credit for attending these live lectures, then you need to become a member over at www.emsconnect.org. Our membership is only $7.50 per month, and you get access to our live sessions as well as our archive that houses over 140 hours of content by our amazing speakers. Also, you can purchase our NREMT 100% online EMT, advanced EMT, and paramedic refresher courses, again at www.emsconnect.org. Sign up today and get educated. Hey, thanks for checking out another episode of EMS Connect on Shift. Please subscribe, review, and rate our podcast on your favorite platforms. Those ratings really help our podcast grow and reach new listeners. Also, make sure to like and follow our social media sites by searching EMS Connect on Facebook, Instagram, and YouTube. Thanks for getting educated with EMS Connect.